Good day, and welcome to the second half of Pulmonary Properties. And now we're going to be discussing a very significant component to make sense of volume, pressure, and flow. And actually, the lessons we learn here, they're going to be so incredibly important to us in terms of all pressures that we ever measure anywhere, because the physics concepts of pressures, volume, flow, compliance, and elasticity, they apply to every surface of pressure monitoring in the human body. All right, and so to begin, I want to remind you that when we talk about mechanical ventilation, we basically have four major factors that we worry about. Is our patient oxygenated? Is he removing CO2? Are their lungs compliant? And is the right heart overburdened? Now that's not for this lecture, but our patients are so critical and they depend on you to utilize this information well and to help make a platform for your physician colleagues to make good decisions. So just to review, remember what P to F is. P to F is PaO2 divided by FiO2 in the decimal, and it should always be greater than 300. If you're on 40% or greater FiO2, it should be greater than 250. Now we're adding in PEEP and we start thinking about strategies. So I wanted to just ask three basic examples. If your PaO2 is 81 and your FiO2 is 0.70, what is your PF ratio? And is that good, bad, or indifferent? If your PaO2 is 100 and your FiO2 is 80%, 0.80, good, bad, or indifferent. If your PaO2 is 65 and your FiO2 is 0.21, is that good, bad, or indifferent? Boop, 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 boop. You've all got a phone, you've all got a calculator, so let's get that done. And the answers are, number one, P to F ratio 115, bad. 70% FiO2 and a P to F of 115, bad. PaO2 100, FiO2 0.8, 80%. That P to F ratio 125, bad. And last, PaO2 65 with an FiO2 of 0.21. Is that good, bad, or indifferent? It's good. The P to F ratio is 309. Now, what does this mean to us? Number one, excuse me, your patient on 70% FiO2, he's not responding to oxygen, do something else. The patient on 80% FiO2, he's not responding to oxygen, do something else. But patient number three, he's got a good response to oxygen, turn up his FiO2. That's why you're using the P to F, to tell you when you need to do something else. Okay, remember about carbon dioxide. Carbon dioxide is about recoil, the recoil of the lung and the time of exhalation that matters. We talk about minute ventilation, which is tidal volume times respiratory rate, and that normal minute ventilation is 8 to 10 liters per minute. So what we want to remind ourselves is the real deal is minute ventilation, not the rate alone, not the tidal volume alone, but the real deal is minute ventilation and the time your patient has to exhale. So let's see what we know. We talked about ventilation, we talked about perfusion, we talked about PaCO2 normal 35 to 45, and tidal CO2 30 to 40, and venous CO2 should be somewhere between 40 to 50. So, step number one, PvCO2 45, and tidal CO2 35, PaCO2 40. Good, bad, or indifferent. PvCO2 59 and tidal CO2 26, PaCO2 50. Good, bad, indifferent. And then last, PvCO2 67 and tidal CO2 50 and PaCO2 56. Good, bad, or indifferent. Pull out your calculator, or really just look at those three in relationship. Remember, PvCO2 is what's made And tidal CO2 is what's cleared, and arterial CO2 is what remains. Boop, 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 boop. All right. Number 1, it's good. Number 2, it's bad. But the question is this about poor perfusion? Because venous CO2 is high, arterial CO2 is high, and end tidal CO2 is low. And number 3, your PV CO2 is high, your PA CO2 is high, your end tidal CO2 is high, you've got hypoventilation. All right, beautiful. So now we've reviewed from our last concept, and now we're going to move forward. And we're going to remind ourselves that the lungs are a two-compartment model. First compartment is the airways. The airways conduct gas down to the alveoli, and those airways do not participate in gas exchange. So we call this a physiologic dead space. That means you have gas, but it's not participating in gas exchange, and the role of that gas is to get the gas to the respiratory bronchioles and to that second compartment, which is the alveolar unit. The alveolar unit is responsible for gas exchange. So everything we talk about in ventilation is how to distend your alveoli and how to let it recoil. Distend, recoil. Oxygenate, CO2 removal. Oxygenate, CO2 removal. So in order to completely understand this, we talk about that oxygenation or distendability as compliance, the ability of our lungs to stretch. We expect our lungs to be compliant, so when gas moves into the alveoli, it distends, and that's when gas exchange takes place. Now we're going to lose compliance in a lung that's fibrotic, in a lung that doesn't have adequate surfactant, in a lung that has alveoli that are filled with secretions or fluids, such as in pneumonia or in pulmonary edema. Elasticity is the ability of the lung to return to its original shape. And that recoil, which is passive, is what pushes the CO2 out into the exhaled mode. And what we need is good compliance for oxygenation and good elastance for CO2 removal. And our normal lung is both compliant and elastic. So, reminding ourselves that lung compliance is about airflow into the alveoli. Remember that alveoli are very thin-walled gas chambers, and there are no muscles, and the air moves in and out of the lungs in response to a pressure gradient. More pressure pushing in, more pressure, big pressure in the lung, but low pressure in the atmosphere, and gas moves out. There are forces that actually resist the lung opening, the alveolar opening. First of all, the tendency of the lung naturally to recoil or collapse, so you have to overcome that to distend it. The surface tension in the alveoli related to the fluid-gas interface, and remember, that's why surfactant is so important. And extravascular fluid or debris, proteins, macrophages, water, basically plasma. So always reminding ourselves there are many forces determined to collapse the alveoli, to prevent you from having compliant alveoli, and our job is to overcome it. So we want to remind ourselves about lung compliance, that compliance is about change in volume per unit of pressure. So I want to make that really, really simple. Compliance is about change in volume over change in pressure. So one of the things that really is important is that we can change the volume when the lung is expanded. We can give more volume when the lung is distendable. And we're going to give less volume at a higher pressure when the lung is less distendable. So when I have a high pressure with low volume, that tells me the lung is not compliant. Once those alveoli are open, gas will go into those alveoli, and that's the underlying structure that we're going to apply in mechanical ventilation, understanding our strategies. Okay, So really important to remember, a highly compliant lung is one that's easy to expand. A low compliance lung is one that's harder to expand. It's more stiff. So that pneumo nugget helps us conceptually when we're understanding lung disorder. COPD is a high compliance. Very aggressive amounts of volume under very low pressure can be delivered into a COPD lung. Their problem is recoil, elasticity. And in pneumonia, because of the debris and the consolidation of the alveoli, that lung is not compliant. There's very low compliance. So putting the same amount of volume into that lung that's non-compliant will be at a much higher pressure. Okay, so very, very important to just basically say, if the lung is stretchy and distendable, tidal volume will be delivered at a low pressure, reminding ourselves that compliance is change in volume over change in pressure. And if the lung is distended, tidal volume will be delivered at a really low pressure. So I have a beautifully distendable lung. I can put volume in there with very little pressure development because it's compliant. So it's like taking your body, if you're a size 10, and putting your body into a size 22 pant. There's no pressure at your seams. However, if the lung is taut, a tidal volume will be delivered at the result of a really high pressure. Again, taking my size 10 body and trying to put it into a size 2 pant. There's going to be a lot of pressure on those seams because too much volume in that non-compliant lung yields a very high pressure. So these concepts of the volume into the compliance yielding a pressure gives us a very significant opportunity and avenue to look at the dynamics of pulmonary physiology and pathophysiology. That is, a given volume into a compliant lung yields a low pressure. A given volume into a non-compliant lung yields a high pressure. A given volume into a very compliant lung yields a very low pressure. So it's the same thing as we talk about with arterial blood pressure. Arteries constricted, pressure's higher. Arteries dilated, pressure's lower. Same volume, high pressure, low pressure. Because actually all pressure, everywhere you measure it, intracranial, intrapulmonary, intrafascial, intra-arterial, and intravenous, all pressure is about volume and compliance. And if we think about pressure in this way, everything becomes easier in terms of how we look at our critically ill population and what our interventions are and what they're meant to prove in our therapeutic concerns for our patient. Okay, so I'm going to show you something that is difficult for even the most experienced respiratory therapist, but I want to show it to you. It's an artistic drawing, so it makes it really easy. It's not the real deal from looking at patients. We will look at this together, though, at the bedside when we're together in clinical. This is called a volume pressure loop. So if you're looking along the horizontal, what you're seeing is pressure. And if you're looking along the vertical, what you're seeing is volume. Now, our lung opens at a certain inflection point. So what I want you to see, first of all, is the dotted red line and the dotted blue line. That's a normal lung. From the point of zero pressure, as we flow gas into a normal lung, you rapidly increase your pressure as you increase your volume until you hit your peak, and then you exhale. So the red dot is inhale and the blue dot is exhale. But I want you to see that the non-dotted lines are representing a lung that is not compliant. So that loop actually shifts to the right. Shifts to the right. It's actually clockwise, shifting to the right. So see the red line going up, opened, and exhale. But by the time volume is moving into the lung, you were already at a pressure of 20. You were already at a pressure of 20 or 18. That means the lung doesn't open until you have gotten to that pressure. Once you got to the pressure, you lift it off of the horizontal to actually deliver the breath into the lung. This is a non-compliant lung. Again, looking at the dots as being the normal lung, you can see here you have a shift to the left. That is counterclockwise, the shift to the left. That volume takes off immediately into the lung till you reach the peak, and then exhalation begins. Now, what that's showing you is that you are moving volume into the lung. So here's the thing I want to say, just as a theoretic set point, because interpretation of volume pressure loops on a ventilator requires a lot of training. And remember, respiratory therapists have a 4-year degree in physics, gas, volume, and flow. We're not getting that from this short survey of ventilatory management and pulmonary properties. But here's the deal. What I want you to look at is in the ARDS lung, in the COVID ARDS lung, in the profound pulmonary fibrotic lung, what you have is a shift to the right in the volume pressure loop. And what your goal is to attempt to shift it more towards normal, which is the dotted line, or even to the left, which is the increased compliance line. And the way that you do that, by the way, is by looking at the point on your graph where the line departs from the horizontal plane. So you can see right where I put that arrow, that's where you depart from the horizontal plane. So if I was sure that I was reading my graph correctly, I would say that my patient needed to be on a PEEP of 18, because the PEEP of 18 opens the lung, and then any delivery of volume after that goes immediately to the alveoli. So that's a concept that's really important. You're not going to make treatment decisions, but you must actually have a good scientific platform so you can discuss with your respiratory therapist, your physician colleagues, your APP colleagues, and each other about what the appropriate strategy might be for this patient, and can we try it? Okay, very good. Now, you're not going to ever really look at that, but we're going to apply that strategy as we move forward. Now, elastance reminds us about the natural ability of the lung and the alveoli to go back to their original shape after that external force, which is the delivery of volume into the alveoli. That's the external force. Once that stops and it's removed, will the alveoli return back to their normal shape? So we always think about this as having an alveoli that's like a rubber band. If you stretch it and then release, it will go back to its original shape. A piece of string you can stretch, but it never goes back to its original shape, and it's not distendable. So distend, recoil, compliance, elasticity, oxygenation, CO2 removal, oxygenation, CO2 removal. These are the properties that we like to apply at the bedside to our strategies of mechanical ventilation and to our understanding about the ventilator, even though we are so fortunate in this rich environment of our ICU that we have persons who are highly knowledgeable and well educated and trained in respiratory therapy. We still, as bedside nurses, must understand these properties if we want to do right by our patients. So, elastance and compliance. Elastance is the opposite of compliance. It's the reciprocal, and it's the change of pressure over the change in volume. As volume goes out, then the pressure decreases. The more elastic something is, the easier it becomes to get rid of our CO2. The more compliant the alveoli is, the easier it is to oxygenate, and also the easier it is to distend it. Not really blow it up. I don't want you to blow up people's alveoli. That's going to cause a pneumothorax, obviously. But to just distend in order to oxygenate and allow time for recoil, which is exhale time, in order to help us get rid of CO2. So we're looking at this beautiful graphic that talks about volume on the vertical and the transpulmonary pressure and water pressure, that's centimeters of water pressure, not millimeters of mercury, that just give us that goal, that understanding of airway resistance. So when you see the arrowed lines that are going up and down on a sideways, those arrowed lines are telling us about overcoming airway resistance, getting gas to the alveoli, thinking about that dynamic compliance. So we're overcoming the resistance and delivering volume into the alveoli. And then the static compliance, which is the dotted line in the center. And what we always want to remember is that in our patients who have changes in compliance, that they'll shift to the right. Patients who have an improved compliance and less elastance, shift to the left. And the elastance is actually about getting to return to your point of takeoff. So you can see you have this perfect little oval football here. Oops. I'm trying to make it like the visual. There we go. That oval football here, right? So it can shift to the right, whoops, shift to the right, shift to the left, or be relatively normal. Very hard for me to coordinate my hands because I'm mirror imaging myself. So, very good. So we just apply this in our lung mechanics. We remind ourselves that there is resistance to the flow of gas, and then there is compliance and elastance at the alveolar level. So very important for us to appreciate. Resistance is change of pressure correlated to the change in the flow of gas. And the elastance is the change in pressure divided by the actual volume of gas. So really important. No one's going to test you on this. You're never going to have to evaluate this even on CCRN or CEN or CNRN or any other C's that you're taking as nurses. You won't really have to differentiate this. But what we want to do is separate resistance into ET tube, tracheal bronchial, alveoli, and compliance to alveoli only. That's beautiful because it helps us to understand what we're actually going to evaluate when we look at pulmonary dynamics. So we're going to talk about three basic pressures. Peak inspiratory pressure, which tells us about resistance and compliance, both together. Trachea, ET tube, trachea, bronchus, all the way to alveoli and incorporating the chest wall as well. That's your peak inspiratory pressure. It should be less than 40 centimeters of water pressure. Now I'm going to move to plateau pressure. Plateau pressure is the pressure inside the lung when gas is static. So we've delivered a breath, we've closed the exhalation valves, and we look at the pressure of the gas across the lung. And that's going to be a measure of static lung compliance. We're going to use that to determine the force that's required to open the alveoli. Now, it may not be the alveoli's actual fault. There might be a pneumothorax, it could be a hemothorax, it could be high transpulmonary pressure, and it may not necessarily be the alveoli, but we are in our class, we're going to talk about peak inspiratory pressure as resistance and compliance, and we're going to use plateau pressure as a measure of compliance. Remember that I must overcome resistance to get to the alveoli. But if I have dysfunctional alveoli, that's also going to affect the way the gas flows through my primary conducting airways. Mean airway pressure is the average proximal airway pressure during the whole cycle of inspiration and exhalation. And mean airway pressure is a strategy that we're going to apply to recruit and open our alveoli and to promote a better gas exchange primarily related to oxygenation. Okay, so I want to remind you again that peak inspiratory pressure is a dynamic measure in response to the flow of gas. The flow of gas. We evaluate that at the bedside on a mechanical ventilator by looking at the peak inspiratory pressure also known as peak, also known as peak airway pressure. Plateau pressure is something we have to measure. We're not measuring that with every breath. We actually press a button, and you don't press that button without a respiratory therapist. The respiratory therapist is going to press that button. That button is called an inspiratory hold. That means gas moves in and valves are closed, trapping the gas in the lung surface. That allows us to look at the pressure at the distal airways when gas is trapped in the lung. It's called a static measurement, and it helps us to evaluate your patient's lung compliance. Because if you have a non-compliant lung, all the FiO2 in the world is not going to improve your gas exchange. We have to open your alveoli. So if you have a pneumothorax, I need to give you a chest tube. You've got a hemothorax, I need to give you a chest tube. If you've got alveolar collapse, I have to open your alveoli, recruit your alveoli so they can participate in gas exchange. So I'm going to use PIP and I'm going to use Plateau, and then I'm going to talk about a mean airway pressure strategy. Okay, beautiful. So now, when we talk about this, we can look at our ventilator on a pressure graph, and look at the flow of gas into the lung till we get to our peak pressure. Peak pressure is the peak flow of gas rushing in. It's known as the peak inspiratory pressure, peak airway pressure. Okay, so PAWP is peak airway pressure, not MAWP, which is mean airway pressure. And then we press that button for inspiratory hold, trapping the gas in the lung and measuring that pressure. That trapping of gas in the lung and measuring that pressure during inspiratory hold means that is how you need to open up the lung. You have to start at that plateau pressure to open the lung. Now, normally we don't start at plateau pressure because it could be extraordinarily high. If you've lost half of your lung alveoli, you're giving the same tidal volume into a much smaller surface area, and that gives you a high pressure. We've got to go above that pressure to open up your lung. So normally we use mean airway pressure for that strategy, and I'm going to talk about that in just a moment. Okay, so again, I want you to see without the overview, peak pressure tells me about resistance, plateau tells me about compliance. Peak pressure, we're going to use 40 as our standard centimeters of water pressure. And plateau, we're going to say we would always like to be below 25 centimeters of water pressure. Now, you can only look at peak pressure and plateau pressure in a volume-controlled ventilation. You can't look at it in pressure-controlled ventilation. So that's going to be very important for us to appreciate and understand. We never measure it unless you're in a volume-controlled mode. Can't measure it in SIMV. You've got to be in assist control in a volume-controlled mode to measure the resistance of the airway to the flow of gas delivering a volume, and the plateau pressure, which is the closure of exhalation valve, trapping gas in the functional lung surface area. So this is, again, a beautiful graphic that tells you that zero pressure is equal to atmosphere, and you can see this patient is not at zero. This patient is at 10 centimeters water pressure. That means we are constantly flowing gas to maintain lung opening at a pressure of 10. Then as the patient gets their delivery of gas for their breath, the inspiration, they will rise up, just like you, rise up to peak pressure. And then we press that inspiratory hold button, and you press that really at the beginning of the breath. The vent will close the exhalation valves at peak pressure. And so then you have plateau. So what you're seeing here is their peak pressure, and then from peak pressure to plateau, that's actually their resistance. Plateau to the end of their breath, which is back down to 10, that's actually the alveolar compliance. So I wish I could point this on your slide, but looking from peak to plateau, that actually tells us about resistance. And from plateau to PEEP, that's looking at alveolar compliance. This is such a wonderful way to evaluate whether or not I have a distendable lung. Okay, so now we're going to look at it really with the vent graphic. The green is representing inspiration and the yellow is representing exhalation. So you can see we have pressed our inspiratory hold. We're looking at their peak inspiratory pressure, and then we're looking at, if you look over to the far right, the P plateau. So the first one measure, 35, that 35 is actually their compliance, okay? And then we look over their dynamic compliance, meaning forcing gas into the lung. It's at 35 centimeters of water pressure. And then when we press the expiratory hold, or the inspiratory hold, we see a P plateau of 28. So we can say it's higher than normal. Normal is 25. I have some loss of my compliance of my alveoli. I actually overall don't have much resistance. The difference between the 35 and 28 is 7. And so that tells us that we don't really have profound resistance ratios. The internal number is another resistance measure, but we're not going to evaluate that just now. We're just looking at peak pressure and peak plateau. Okay, now the problem here is that when you have loss of alveoli, all your volume of gas goes to your open alveoli and over-distend them, which then causes overstretch, causes stimulation of inflammatory mediators, and can actually cause a loss of your functional alveoli. So this is why we worry about peak plateau pressure, because what it means is I'm delivering gas to functional alveoli, but I'm not popping open the dysfunctional alveoli, and my number one goal is to open dysfunctional alveoli. So we want to be very aware of this in terms of our pulmonary properties and what we wish to do at the bedside. So I want to just say, if I'm measuring my patient, remembering that 40 peak is typically about what we accept, 40 or less, and 25 plateau or less is what we typically evaluate. If you have a high peak but a low plateau, that's a resistance problem. Your patient may have a mucus plug, he may have a bronchospasm, he may have his tube may be only in one airway, it might be below the carina, and the patient might be biting, tonguing, forcing the tube around and manipulating his tube. That's a high peak with a low plateau. But a high peak with a high plateau typically indicates loss of alveolar compliance, which also communicates to resistance. And that's ARDS, pulmonary edema, pneumothorax, ET tube migration to a single bronchus, and pulmonary effusions. So you can see how helpful this is to actually evaluate at the bedside. When you're struggling with your patients, high peak inspiratory pressure, the most common alarm at the bedside, you actually need to communicate with the respiratory therapist and ask to do an inspiratory hold. So when we're thinking about the vent, we just want to remember, if peak pressures are high and plateau pressures are low, meaning less than 25, you have an obstruction to the flow of gas. You have resistance. If both peak and plateau are high, you have a lung compliance problem. So always important when you have high peak pressures, you might come in the room, you see that the patient is going, you're pretty sure you know what the problem is. The patient is combating the vent and they're combating the ET tube. Now, I'm just going to remind you that when your patient is dysynchronous with the vent and agitated, maybe you need to look at how the vent is supplying gas for the patient. You certainly are going to think about sedation, but you also need to consider that sometimes patients are feeling suffocated because the vent isn't supplying the flow of gas rapidly enough for the patient. We're going to talk more about that when we really talk about ventilatory strategies, but it's something I want you to keep in mind when you're evaluating your patient. Okay, so now we're actually at one of our vents at the bedside, and what you're seeing in the first two is the flow of gas and then the flow out. The flow of gas and then the flow out, okay? And below that, you're seeing the pressure in the circuit and the pressure in the circuit. And then I pressed my inspiratory hold, so you can see that instead of having a peak and then down, you have a little plateau. And up in your upper right-hand corner is the plateau pressure. Now this patient has a plateau pressure of 16, and his peak pressure is actually around 22 or so. So I wouldn't have even normally done a plateau. I only did that so I could take the picture so I could show it to you. Okay? So plateau pressure appears in the upper right-hand graph, says PPL, P plateau, displaying the pressure when the exhalation valve is closed and gas is distributed across the open lung. The less open the lung, the higher the plateau. And our goal is to open your lung. And if you're going to deal with COVID patients who have intubation on ventilation, this is going to be a major strategy in terms of the way that you're evaluating your patients. Okay, so let's see what we know. Your P peak is 51 and your P plateau is 25. Is your problem resistance, compliance, or both? Second, your P peak is 58, your P plateau is 42. Resistance, compliance, or both. Third, your P peak is 41, your P plateau is 40. Resistance, compliance, or both. Ding, 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 da, 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 do, 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 do. Let's look at the answers. I hope you got it right. Number 1, the problem is resistance. Bronchospasm, mucus plug, biting, fighting. Number 2, both. Resistance is up, P plateau is up. Both. And number 3, compliance. So for resistance, we're going to deal with obstruction. For both, we're going to start with compliance and then think about obstruction. And when it's compliance only, we got to open that lung, baby. We have to open that lung. And we've got to do it sooner rather than later. So bringing that together with oxygenation and CO2 and looking at the pressure measurements of our patients, even if you don't understand one lick about mechanical ventilation, just remember we flow gas into a chamber and it's either compliant or non-compliant. There's either resistance to the flow of gas or compliance in relationship to the flow of the gas. And our responsibility is to evaluate and know the difference so that we can communicate effectively and so that we can strategize about what's right to do for our patients. Now last, I just want to talk about mean airway pressure. Mean airway pressure is an average of the pressure during the entire respiratory cycle, and it is the strategy that we are going after when we are using PEEP, when we are using CPAP, when we're using expiratory pressure with BiPAP, and when we use pressure control ventilation, airway pressure release ventilation, and high frequency oscillation. So, mean airway pressure is the average of the peak, the area under the curve, and the exhalation pressures. So you can see your mean airway pressure here, and even better, looking here. Mean airway pressure is the area under the curve of both inspiration and exhalation divided by the duration of the full cycle. One full cycle of in and out. The mean airway pressure is typically what drives our application of PEEP, our application of high pressure and APRV, our application of CPAP or EPAP. Most of the time it requires a high level of evaluation, but in our current ventilatory mechanisms, mean airway pressure is always displayed at the top of the screen. So very important for us to appreciate that mean airway pressure as an indicator of whether or not our alveoli are opened and how we should be opening them, because typically we're going to say mean airway pressure is the pressure that actually opens your lung. Excellent. So when FiO2 is not enough, your patient has a PF that's poor, and the lung is non-compliant, meaning your plateau pressure is high, your goal is to assure that it's not because of a hemo or pneumo or some chest wall rigidity, but if it's actually alveolar, the whole goal will be open your alveoli. That's called alveolar recruitment. And the way we're going to start that is to increase the mean airway pressure by increasing our PEEP. We increase PEEP to open, and we increase PEEP to maintain opening. And then we also talk about applying a higher pressure for a long period of time. So gas flows in and maintains its flow for a long period of time. And there are multiple strategies that we can use that. I'm only introducing you now to the term. We're not talking about it now. We'll talk about it in advanced ventilation. Prolonging the I time but not allowing your patient to breathe. That's called pressure control, controlling the pressure, inverse ratio ventilation. Or high time, high pressure, longer time, patient breathing very small amounts across their high time, and then the pressure is released. That's known as APRV. So we'll talk more about those strategies very generically because we're not trying to be respiratory therapists. We're just trying to improve our understanding of what's occurring at the bedside so that we can actually work together as part of a team in the application of strategies that recruit our patients' lungs and that we're aware if they are failing. And that's the most important thing, to be aware when the strategies we use are failing so that we can move to the next step. And remember, your number one role is to be the physician's eyes and the patient's voice. And nowhere is that going to be more true than in the basic understanding of pulmonary, cardiac, hemodynamic evaluation in a critically ill patient. So, just as the last adage, just to remind ourselves that we have lots of ventilator alarms. They can be high pressure, they can be low pressure, and they can be about volume. We'll look at all these alarms as we evaluate and talk about troubleshooting mechanical ventilation in a way that we as nurses can do. And to be aware that ventilator alarms give us a cause for concern. And we always have to be aware that the ventilator is alarming us to a problem with gas delivery. And if you can't deliver gas into your patient's lung, then you are doing them a disservice. So we always have to pay attention. We want to understand P to F. We'd like to understand OI. We want to think about ETCO2 and ventilation and perfusion matching. And then we're also going to think about peak inspiratory pressure and peak plateau, all tied up in a bow in order to apply appropriate mechanical ventilation strategies at our bedside. Use those pressures. Remember, high peak with normal to low plateau. This is about mucus plug, bronchospasm, ET2 blockage and biting. High peak and high plateau, ARDS, pulmonary edema, pneumothorax, hemothorax, ET2 migration into a single bronchus, or pulmonary effusions. We have a responsibility to pay attention. That's our job, and that's what we do best. Just remember, pressure changes when you put multiple sardines into a sardine can or multiple humans into a subway. It changes the pressure within that chamber. And when we talk about a sardine can or a subway car, they are not distendable. Thank you so very much, and I look forward to our next sequence. Thank you.